So, where is Swaraj? Just give me a minute, sir. Oh. Swaraj, please. Dr. Swaraj.
I was trying with some issue with the mobile.
Okay.
So I am just laptop on. Just it.
Yeah.
Yeah, Dr. John has joined with some other's mobile. Hello. Better up.
No, I have joined, sir. I joined.
With Better Up's mobile. So please change the name.
Dr. Swaraj, please. I think we will start, sir.
Yeah. So good evening, everybody. Acha, no, countdown has to be given, na?
No, it's already given. Actually, since you were not there, we just waited.
Okay. So good evening, everybody. We are here again for the ARC webinar from the Eastern India Zonal Ophthalmic Congress. Today's topic is approach to a case of microbial keratitis. We had with us our President, EIZOC, Dr. Pranab Ranjan sir, Vice President, Dr. Jayanta Barua, Dr. Lobsang, Joint Secretary, Dr. Shabboshachi Patnaik, the Chairman Scientific Committee, and Professor Y. Kingsui Miti. He is our Chairman ARC. We had our panelists today, Dr. Nilesh Mahan and Dr. Reena Singh, and speaker, Smruti Rekha Priyadarshini Madam from Odisha, and we had our moderator, Dr. John Sarkar. Without wasting any more time, we now hand it over to the ARC chairman to continue with the program. And before that, I request our president to give a welcome speech for 2 minutes.
Thank you, Dr. Swaraj Bhattacharya. And on behalf of EIZOC, I welcome you all to the ARC webinar, an important topic. Thank you, Dr. Swaraj Bhattacharya. And on behalf of EIZOC, I welcome you all to the microbial keratitis, which is not only important for the residents and PGs, but also to all the ophthalmologists. I welcome today's speaker, Dr. Smruti Rekha Priyadarshini from LBPI Bhubaneswar. To take us through, we have Dr. John Sarkar, who will moderate the session and will initiate a lively discussion with our panelists, Dr. Nilesh Mohan and Dr. Reena Singh. I wish to thank the EIZOC team, ARC Chairman, Professor Y.C. Maiti, Chairman Scientific Committee, Dr. Sabyasachi Patnaik, Joint Secretary, Dr. Lobsang, and above all, our President-elect, Dr. Jayanta Barua, and Secretary, Dr. Swaraj Bhattacharya, for their relentless cooperation and guidance. Last but not the least, I welcome all institutions of the East for which this ARC webinar is being organized. Over to you, Dr. Mati sir, to carry forward the program.
Good evening, sir, and thank you, Mr. President, sir.
Over to you, Professor Dr. Mati.
Yes. Very good evening, Mr. President, sir, and Secretary, sir. Today we have the seminar, the moderator of today's session, Mr. Dr. John Sarkar. He is a senior consultant in cornea, cataract, and refractive surgery at the Sushrut Eye Hospital, Kolkata. An expert in the state-of-art cataract surgery and premium IOLs, he is also a prolific cornea transplant surgeon and regularly performs refractive surgeries. He has completed his MBBS from RZKR Medical College, Kolkata, and did his diploma ophthalmology from RIO Kolkata, and he completed his master's in surgery in ophthalmology from the Assam Medical College in Dibrugarh. Dr. Sarkar has done his long-term fellowship in cornea and refractive surgery from the Sankara Netralaya, Chennai. After that, he worked as an associate consultant in SN Chennai, later on shifting to Sankara Netralaya, Kolkata, after which he is presently joining in the present state. He has presented several scientific papers, video posters, and faculty in many various national and international conferences and has several awards in his name. Dr. Sarkar has about 10 international presentations and surgical videos in various international and national conferences, including ESCRS and the World Ophthalmology Congress. He won the Best Thesis Award in AMCH Dibrugarh 2001. He has also delivered 3 orations in various national conferences. He has won the second prize in Best Scientific Paper in Kerakon 2014 at Mahabalipuram, Tamil Nadu. He has also won the Best Surgical Video in Ocular Trauma in November 2020 from the Ocular Trauma Society of India. He also won the Best Surgical Video in EIZOC 2022. So let us welcome Dr. John. From now on, please carry on the program. Thank you, Dr. Dr. John, please.
Good evening, sir. Am I audible, sir?
Yes, yes.
Yeah. So thank you, sir, for your kind words. Thanks to all the respected seniors here. So without wasting much more time, I think we'll just introduce our today's. I'm very thankful to the EIZOC ARC for giving me the opportunity. So the topic of the today discussion is approach to a case of microbial keratitis. I think all of us as day to day is a very common topic, and sometimes we are really dilemma. So why not we take the opportunity from our own society member? We are the expert of that field. So that's why very nicely you decorate the program by yourself, sir. So we have today our expert, Dr. Nilesh Mohan, sir. I'm sharing. Professor Nilesh Mohan, sir, we have with us for the expert panel. Presently, he is the Professor Nilesh Mohan. He has done his postgraduate from the RP Center AIMS, New Delhi, and he has 25 years experience for PG teaching. And he has multiple several publications and award winner. And presently, he is heading the department of the RIO Patna. We have with us with another expert panel, Dr. Reena Singh. She's from the Ranchi, ma'am. She has done the MBBS from the Rajendra Institute of Medical Science, Ranchi, 2022-27. He has done MD Ophthalmology from RP Center, and she has several publications in Index Journal and several award winner. Along with that, we have our today's the speaker is there, Dr. Shruti Rekha Priyadarshini. She is presently working as a consultant in LB Prasad Bhubaneswar. She has done his MBBS from the Bhubaneswar, then followed by the long-term cornea fellowship from the prestigious Madurai Arvind Hospital, and she has several publications and lots of experience, and she has lots of presentations. So, over to you, Dr. Priyadarshini.
Thank you so much for your kind words. And let me share my screen now.
Just go down. That is the screen share option. Yeah, yes. Sharing.
Yeah. Just a minute. Try to. Just a minute. I've switched to a new system, so trying to get used to it.
Am I audible, Dr. Shruti Rekha?
Yes. And
Madam, just
some
see there's the
issues-
right corner, there's a share option is there.
Yeah, I can see that, but I think there is a issue with this. No. Just a minute.
Do you have a backup system, ma'am?
I have. Maybe I should, yeah, maybe I'll log in through my other, I'm really sorry for this.
No, that's okay.
Close whiteboard. Okay. Just let me see if I can.
In your screen, go down, there's a share screens option is there.
Microsoft
Yeah, click that option.
No, some screen recording. Okay, let me get back to my older system. Just give me 2 minutes.
No issue, no issue. Take your
Yeah.
time.
No issue,
Just
I
ma'am.
think
log
meanwhile,
out
Mr. Rahul Jain is there, na, technical support.
Yeah, Rahul is here. Yeah,
Can you, Mr. Rahul, can you just sort out the issues?
No, but he'll
But
have
Dr. Priyadarshini
limitations
is a
because
little difficulties for them.
he'll have limitation because ma'am is working on our own system. It is from our end, So I think there's no. I think she has signed out and she'll be coming back with the other this thing, alternate. So let's just no. She's the speaker. We have only one speaker, so I think we'll just give 1 minute. She's coming back. She said, okay. There are some issues with ma'am Priyadarshini's this thing. So that is why, sir, we are waiting for. She's signing back with another this thing ID. So we'll just give her 1 minute. Sorry.
I think this is the scenario. That's actually better to, if you share your screen with the technical team, then some issues are there, they can run the slides.
Extremely sorry for the
Ma'am.
technical glitch.
Yeah. Okay, ma'am. Are you ready now, ma'am?
Yes, I should be ready with my.
Okay, please.
Are you able to see my screen now?
Yeah. It's coming. You make it full screen.
Okay. Is it
Yeah.
full screen now?
Yes, absolutely.
Yes, it is visible. Yes, it is visible.
Yes, ma'am. It is
Yes, sir.
very nicely
Perfect.
visible.
Very nice
Huh.
to meet.
Yeah, this is my old laptop, so unfortunately, I would- you want
Yeah.
Else, what we can do? Else, we can go ahead with the presentation, and during discussion, she can come on the mobile for the discussion.
I think better we start the presentation.
Yes, Dr. John, I think we should start the
Yes.
presentation and discussion. She can come on video, and we can have that.
Yeah. Please let us. I think, madam, let us do like that. You please start the presentation, and then while we want to see your video, please join with your mobile.
Sure. So thank you for this opportunity. This is a topic which is quite commonly we encounter in our clinics. So I thought approach to a case of microbial keratitis would be a good topic for all for all the PNB students and postgraduate students. So microbial keratitis is the leading cause of blindness worldwide. Incidence is very high. The global estimates are about 1.5 to 2 million cases per year, and this is probably an underreporting. And the incidence is more in the developing countries. It is also known as a silent epidemic, and it is often we see in our emergencies as it's also a case of ocular emergency. So if we come to one of the studies, which were this is actually a collaboration of this is a combination of many studies, and this map we can see that in Northern America the incidence is very less, the prevalence is very less. In Europe it is slightly more, but when you shift your focus to South and Southeast Asia, the numbers are huge. It's except for one study which was conducted in Hong Kong. In so the other
It's a request to all the speaker. Can you just mute yourself?
So I'll be discussing the presentation in the following outlines. First is the risk factors, the clinical history, clinical examination, laboratory diagnosis, and finally the treatment. So coming to bacterial keratitis, if we based on the gram staining, they can be divided into gram positive and gram negative. Again, gram positive are cocci and bacilli. This is how they look like in a gram staining. Similarly, gram negative can also be divided into gram negative and cocci and bacilli. So the other thing that we all, at least people from an agricultural background, are should be aware of is the fungus, which can be divided into filamentous and non-filamentous. And yeast, of course, they can also be pigmented and non-pigmented. So usually for the postgraduate students, fungus, they can be seen in a gram staining. But if you do a KOH mount, then it dissolves the cell walls and it dissolves the surrounding debris, and we can see the cell walls in a better way. Similarly, if we do a fluorescent, if we see them under fluorescent microscope, the filaments can be seen, and filaments as well as the yeast can also be seen in a greater detail. So the most common organism in the Western world is herpes, but in the developing countries, especially India, fungal infections are the most common. So coming to the predisposing factors, Dr. John, please feel free to stop me, or if you want for a discussion, then I can please let me know. We can stop there and we can do the discussion simultaneously. So the predisposing factors, systemic factors are those ones which causes an immunosuppression, like diabetes or a leprosy, tuberculosis or alcoholism. I had seen a case long back where bilateral epithelial defect were there, and the patient also contracted infection in both the eyes. Similarly, rheumatoid arthritis and other collagen vascular disease, since they cause a defect in the ocular surface and the patients are already on immunosuppressants, they also predisposed to in microbial keratitis. Poor ocular surface seen in Stevens-Johnson syndrome or a vitamin A deficiency where there is a epithelial background or a melt, we can see infections. Other causes are measles, burns, HIV, and other allergies. The ocular conditions where we see infections are following any surgery, since they are put on steroids, then it it causes local suppression. And some of the surgeries that we see in our OPDs are after keratoplasties or after cataract surgery. Wherever the cornea is decompensated following like a corneal edema, it allows the infection to grow very well. A coexisting dry eye, say again Steven-Johnson, and any lid pathology like entropion, trichiasis, or a blepharitis, coexisting dacryocystitis also. So this is this photo I had taken from one of my case seen 1 month back, where I done a collagen cross-linking, and 5th day the patient came with an infiltrate. Scraping showed Pasturella species, and it was susceptible to just 3 antibiotics like chloramphenicol, colistin, and gentamicin. So I started the patient on colistin, and the patient is recovering, but unfortunately there is a scar which is there right in the visual axis. This is one of baby that comes to my clinic. Again, presented with bilateral corneal infiltrate, very small ones, but patient is not very symptomatic. So when we tested, it was found that patient had a congenital corneal anesthesia. So recovered well with antibiotics, but we did a tarsography, permanent tarsography, so as to close the eye. This is another case of rheumatoid arthritis with a poor ocular surface. We can see how bad the surface is, and these surfaces usually they are prone to infections. Even the commensals can also become infectious here. This was a few years back. A patient had this is a fisherman by occupation and had a fish hook injury, and came to my OPD with the hook inside, and we had to take him to the OR and remove the hook. But unfortunately, the went into end off, and we had to do a therapeutic keratoplasty. But we could not without any vision potential, we just did a tectonic keratoplasty. Sometimes medications also predispose the eye to infections, like systemic infections and ocular medications, mostly antibiotic, antiviral, antifungals. Here, normally, whenever we do not have a microbiology backup with us, we try to flood the eye with a cocktail of antibiotic, antiviral, and antifungal medications. So what they do is they do more of a harm than any benefit. They suppress the commensals, and that is how the pathogens they try to proliferate. So this is a practice that should be stopped, and microbiology-based treatment should be encouraged. Steroid, again, it is also a local immunosuppressive, and they are wonder drugs, so they are also available over the counter. So many people they can get this medications like from like an Ocupol D or any as steroid combination, and they just use it, and that's how they end up in infections. Native and home remedy. During my experience from my Arvind days, I have seen people putting cow's milk, breast milk, even hen's blood into their eyes for remedy. Anti-glaucoma medications, since they have preservative, they are like BAK. So back usually it's not a very surface-friendly drug, and that is how they end up in all kinds of infections. So this photo I have taken from today's OPT. This was a 65-year-old female who came with a history of rheumatoid arthritis. She was already on biologicals on and off. She went to homeopathy, allopathy, Ayurvedic, all sorts of medications. And she was actually referred by a local ophthalmologist who had checked her vision 2 weeks back to be 6/24. And this was the best eye. So today when she came to my OPD, she was on prednisolone acetate 6 times and anti-glaucoma medications treated for scleritis. But yesterday night, she had a perforation, her lens had come out, and that's how she came to the emergency. And then I saw her in the OPD. So when we start off any ocular examination, the examination of the corneal ulcer should always be, should not be limited to just the cornea. We should go from anterior to posterior. So eyelid should be looked for the presence of any blepharitis, trichiasis, entropion, ectropion, anything that that compromises the good closure of the eyelids, or any infection which is harboring on the lids can be a source of infection. Similarly, lacrimal sac, the chronic dactylocystitis, again, it also harbors organisms like Streptococcus pneumoniae. And that is why in all our ulcer patients, routinely we should do a nasolacrimal duct, we should do a syringing to see that it is not blocked. Tear film, conjunctiva also should be looked for signs of any conjunctivitis or chemosis, and the tear film should be evaluated to see for any dryness. So whenever we are examining for any corneal ulcer, first of all is the location, whether it is central, peripheral, or total, and whether it is close to the limbus. Size, again, size of the epithelial defect and size of the infiltrate. This we should do with the help of help of the graticle, which is there in the slit lamp. There are also many apps which are available now to measure the size. But I come from the era of MUT study, where during my fellowship in Arvind, we were, as a senior fellows, we were also we had the scope of measuring the ulcer, epithelial defect, infiltrate, hypopion, and enroll patients accordingly. This is very helpful, especially in monitoring the progress and the response to treatment. Depth of the infiltrate, by making a slit, we can know whether it is limited to the anterior to mid to posterior, or whether there are any endoexudates present. Margin of the ulcer, we should look for round punched out margins, as in bacterial. They are the round margins. In fungal, they are feathery margins. Or the surrounding cornea also should be looked for cellularity or presence of any satellite lesions. This is a case where we can see that there is a. Would any fellow like to describe the ulcer here, the infiltrate? Can we do that, Dr. John? Will they be
Yes,
able to
yes.
participate and describe,
Yeah.
or is it going to take time?
I think, can you just cover, because if some technical slang will be there, so probably first you finish it off, then we can discuss, and everybody can make a group discussion. I think it will be much better.
Okay, sure. So this is an ulcer where we can see that the edges of the ulcer, they're very irregular with a hyphae extension. And if you look at the surface, they're very dry looking. So these kind of pictures, usually when we make a diagnosis of a fungal keratitis. So typically they give a history with trauma with vegetative matter. It may not be there in 100% of cases, but most of the time when you ask them a history, there will be some history of trauma, and then a patient may be on steroids. So we have to take that history from the patients. So onset between incidence and clinical findings is usually 1 to 2 weeks, and patients complain of insidious onset of pain, conjunctival ingestion, photophobia, and diminished vision, and typical signs more than symptoms. So when we this is a photo where we can see that there are hyphae edges with a hypopion. satellite nodules, a pigmented plaque, and this is also a pigmented plaque. So so these are a few of the typical signs of fungal keratitis. So how do we manage them? First of all, we have to confirm the diagnosis and lab-based diagnosis and culture. Also, even if we do not have an access to a lab, a simple KOH is something which can help us in differentiating between a bacterial versus fungal. That takes care of in most of the cases. So first of all, we have to confirm that it is a fungus, and second is we have to also eliminate any superadded infection. In management, we have topical and systemic. I'm not going into detail because this is again another chapter to discuss. But the first line of treatment in on-filamentous fungus still remains natamycin, and for yeast it is amphotericin B. Amphotericin, it is usually not available over the counter, and we have to formulate and give it. Again, oral also we can give either itraconazole or fluconazole. Before doing it, before prescribing, we can do a liver function test, and then we can prescribe the drugs. So this was a case where a 43-year-old male presented with a fungal keratitis and started on natamycin hourly. And within a few weeks, we can see that the ulcer has reduced. There is a rounding of the perimeter of the lesions. The feathery margins have there's loss of the feathery margins, resolution of the satellite nodules, density has decreased, scarring has started, and there is an improvement in the visualization. So this is how a corneal ulcer heals. So this I want to focus that there are certain organisms which are associated with some risk factors. For example, Staphylococcus organisms, suppose patient has a previous herpetic disease or a dry eye, mebomitis, or a bullous keratopathy. So the most common organism we can think of is a staphylococcal. Similarly, if a patient has a chronic dactylitis cystitis, then Streptococcus pneumoniae would be the organism which would be there in the top list. Again, extended wear contact lenses, even though this is mostly seen in the Western population, but also Pseudomonas is an organism which we see in extended wear contact lenses, HIV positive patients, and in comatose patients. If there is a injury and there is typically exposure to soil, then bacillus. In malnourished diabetic immunocompromised patient, moraxella. In human and animal bites, it is an anaerobic organism, and this was also has been seen in Western literature that surgical procedures like classic, it's a typical mycobacterium from the blades. We can just keep this in mind when we are thinking of any particular organism. So coming to a few of the bacterial keratitis and their typical features. So staphylococcal keratitis, usually they'll have they're very localized lesion with a distinct margins. There'll be clear surrounding cornea. They can also spread deeper, causing abscess, and they can cause mild to moderate kind of an anterior chamber reaction. Whereas if you look at streptococcal keratitis, they are, as I mentioned, they are associated with chronic dactylitis cystitis, and they tend to go quite deeper with a severe anterior chamber reaction and a fibrin reaction on the endothelial surface. Pseudomonas can present very rapidly, progressing in hours and melting the cornea in few days. It starts with epithelial defect. There will be edema, microinfiltration within few hours of trauma, and it can just perforate within few days. It can present as a ring ulcer, or it can appear as a satellite nodule. So we should not underestimate this organism, and it is always good that to do an early therapeutic keratoplasty if we want to save the eye. Nocardia, typically you can see it is described in literature as a wreath pattern. Wreath is the flowers that usually given in the Western countries in for funerals and graveyards. So typically it presents as a raised wreath kind of a arrangement, And the method how to diagnose is a gram staining, and further going with a modified Zn staining, which is 1% H2SO4 staining. You can see that 3 thin beaded-like structures in the modified Zn staining. Acanthamoeba keratitis, typically they present with a ring-like infiltrate, and they have radial keratoneuritis, where the only thing which we can say that which typically demarcates this from other ulcers is the severe pain, that the patient rolls in pain because of the radial neuritis, and they can be very dangerous. This was one of our case where one of our patients who presented had a history of 2 months and presented with the endophthalmitis, and we lost, I mean, it became thysical after management. So they usually present as double wall cyst, but many a times they are not quite diagnosed in the first scraping, only when we have a high index of suspicion and the clinical picture. So we can do a scraping so that we can establish the diagnosis, because the treatment is not like any other bacterial. We have to give PHMB and chlorhexidine, and so that is why it is very important to isolate this organism. Microsporial keratoconjunctivitis, again, since Odisha is a coastal area, we see a lot of patients coming to us, especially during the rainy months with scores, SPKs. There will be elevated lesions stuck on appearance, and they may be present unilaterally or bilaterally. And when you take a history, they'll typically give a history of exposure to muddy water or rain, or even going to a seashore. So they usually resolve with this is how they look in the they appear in the fluorescent microscope. Most of the time they do not require any management. We have done a randomized control trial here, but finally it was concluded that they resolve well with lubricating eye drops alone. But if the patient is very symptomatic, we can just do a therapeutic debridement. We can just remove the epithelium and put a bandage, contact lens. The patient will resolve in 1 to 2 weeks' time. Sometimes they also present with microsporidial stromal keratitis, where we can see that they're grayish white-like lesions. And the thing that we have noticed is there will be KPs which will be beyond the lesion. And even though there are a few case reports which say that they resolve well with voriconazole or PHMB, but most of the time we have to do a therapeutic penetrating keratoplasty for the better. Again, treatment should be based on whether it is a gram positive or a gram negative organisms. So smear will help us with this. If it is a small organism, if it is a small ulcer and a gram positive organism, then we can go for any fluoroquinones. Or if it is a large ulcer, then we better go for a fortified cefazolin. Then we wait for the culture and sensitivity. Based on the sensitivity report, we can change it. It's not only the sensitivity report, but also the response to the first treatment. So we have to do a permutation combination and take the help of like what is working for the patient. So based on the sensitivity and based on the response to treatment, we can change it or continue the same medications. Adjunctive treatment, cycloplegics, anti-glaucoma medication can also be given. Steroids, again, it is a very gray area. The SCUT trial has proven that steroid do not do not decrease the scarring. So only if the patient is very symptomatic, like if there is a scleritis, like an acanthamoeba, or where there is a graft infiltrate and we want to preserve we don't want the graft to fail, become edematous and fail. Only in those special cases we can give them. Otherwise, for the postgraduate students, you should remember that do not say steroids in front of your examiners. You can just omit this, and you can remember cycloplegics and anti-glaucoma medications. So difference between fluoroquinolones and fortified drops. Fluoroquinolones are cheaper, available over the counter. They are stable. once we open the bottle, the vial, it can be used till 1 month. They're less toxic, and they have the recent ones have, but the older generation, they have a poor gram-positive coverage. The fortified ones, they're expensive. They need to be prepared. They have to be refrigerated. They have a shelf life for 1 week. They're more toxic. But having said so, we also did a study in our lab where we saw that the efficacy and safety of cephazolin eye drop is good even in room temperature. This is unpublished data, and it can be safely kept in a room temperature and need not be refrigerated. Again, this is another entity which is, I think, during my fellowship days, I say way back in 2010 and 11, when I was doing my fellowship at Arvind, we used to have many cases of keratitis who just come with a perforation, and the microbiology report would say unidentified dematicious fungus, unidentified hyaline fungus. So we used to think that what is this organism, and till I think in 2015, 14, 15, I think Pythium was discovered, and people came to know that Pythium almost resembles fungal infections, the fungal hyphae, and that is why they were classified then as unidentified hyaline fungus. But because of the cell wall differences, they do not respond to antifungus, and that is why many of the patients deteriorated and came back with a perforation. So usually they have a very hyphae edges. Initially, they will be like dot-like infiltrates. Then the next step will be hyphae edges. Then there will be guttering, and then there will be perforation. This is how Pythium progresses, and the treatment is linezolide 0.9%. So linezolide again has to be formulated, but the formulation is pretty easy. This is how it will be seen in a fluorescent microscope. There will be slightly larger, broad acetate with folds, they ribbon-like fold. So they're folded on each other. So this is how it's very tricky, and it needs a good acumen to distinguish this between Pythium and fungus. And this is the stain, IKI stain, iodine potassium iodide stain, which stains it as black color, sorry. So coming to viral keratitis, even though this is an entity which is commonly seen in the developing world, in the developed world, but still we also have seen some of these cases, and we also see some of these cases in our clinic. So HSV1 is the most common virus causing viral keratitis, and it is the viral keratitis is thought to be a reactivation of virus in the sensory ganglia. The virus, once the patient is affected, that's a primary infection, the virus migrates down the nerve action to produce lytic reactions, and it may remain latent within the corneal tissue, serve as a potential for recurrent disease. So, so we can see that in one of the photos, there is a dendrite. So the epithelial lesion usually presents as a dendrite or in a geographic pattern. It may present also as a stromal non-necrotizing or a necrotizing stromal keratitis or a keratouveitis, and sometimes with a marginal ulcer. Varicella zoster infection occurs in two forms, primary and recurrent. Ocular manifestations are uncommon in varicella, but seen in ophthalmic zoster infection. This is how it Hutchinson sign typically we see them in some of our cases where they obey the midline, and you can see the bullous, vesicular bullous lesions. They can also present at small bullae or keratouveitis, or sometimes with a frank ulcer. So laboratory diagnosis begins with coming to how to diagnose. So laboratory diagnosis begins with a direct observation of the sample under microscope, which provides a rapid diagnosis. You just scrape it, make the patient wait for half an hour or 1 hour, and then perform the grams and QOH, and then you should be able to, most of the time you should be able to get the organisms. Then it can be confirmed, this finding can be confirmed by culture, and if required, a molecular diagnosis can be done, or a PCR. So first of all is smearing on glass slides, grams, KOH, and GIMSA. Then a few media that we do routinely is a blood agar, chocolate agar, SDA, non-nutrient agar, and brain heart infusion. So first of all is having all the media and the culture slides ready. Drop of proparacaine on the cornea, scraping the leading edge and the center of the ulcer with a spatula or a Kimura spatula or a 15-number blade. The grams and cuboid smear is prepared first, and then the C streaks are made on the culture media, except in NNA media where it is just planted on the center and not as C streak. The other investigation modality that also helps is the confocal microscopy. So especially in acanthamoeba where the yield from a smear or a culture is less. So in these cases, confocal can help us look at the cyst. Sometimes in pythium also it can help us. So antibiotic susceptibility, it helps us in giving information about the MIC level. It also helps us which antibiotic will work with, but it is not done in fungi. So the general approach is we have to start an initial antimicrobial therapy based on the direct smear examination and then modify or continue therapy based on the result of culture, antimicrobial susceptibility, and the clinical response. So it has to be three things. One is the culture, susceptibility, and the response to the previous treatment. Surgical approach only when required, and monitoring. So this is, I think, one of the things that I feel. I mean, some of our patients are they are not ready to come every 3 days. So I think based on the severity, 1 week or 10 days should be good enough. So signs of worsening, we either call it as a non-response or a resolution. So non-response, when we see that there is an increase in the size of the infiltrate and the epithelial defect, also the hypopion. So that is why measuring the ulcer and noting down these parameters are important. One is the epithelial defect, size of the infiltrate, and the hypopion. Thinning, again, we have to see whether it is 60%, 70%. If you document this nicely, then it will also help us avoid perforations. Resolution is apart from the visual acuity, I think that is not the first criteria. The first thing is resolution, which means decrease in signs and symptoms. Epithelialization improves, necrotizing tissue is replaced by scar, vascularization, and the edges become slopy. So this is how we define as resolution. Surgical management can be done in terms of applying just a tissue adhesive, giving an intrastromal or an intracameral injection, superficial keratectomy, and in advanced cases, doing a keratoplasty. And off late, collagen cross-linking and PDT have become they are now in experimental mode, and some places have started doing it, but again, it is not very widely used. So these are some of the conditions where we should not wait for the medical management to, we should not, and we should directly go for a surgical management, like large perforations, very large ulcers encroaching towards the limbus, very deep corneal abscess, and already perforated ones. So these are the indications where we should go for a surgical interventions. Superficial keratectomy, especially in fungal cases where there is a plaque. So we can just do it, we can do the scraping in a 15-number blade in the OPD or in the OR. This will cause reduction of the fungal load and lead to better penetration of the antifungal medications. But there has been a RCT where it has been seen that scraping can worsen the best corrected visual acuity because it causes stromal thinning also. And then the next is a cyanoacrylate glue. This is a lifesaver. Sometimes it's a compound known as N-butyl cyanoacrylate. And in cases of progressive thinning or small perforations less than 2 millimeter, we can think to we can think of sealing the perforated area with a cyanoacrylate glue. And it also helps us to buy some time till a penetrating keratoplasty is done. So especially when you do not have a direct access to tissue, you can just put it even though you know that in large ulcers, this may not help, but it will help you buy some time. But whenever it heals with a scar and along with vascularization. And once it is placed, we can wait for 3 months till the underlying stroma kind of slightly the stromal fibers are laid, and then only we can remove the tissue. Cyanocolate glue. Sometimes in recalcitrant deep fungal keratitis, you know that the medication, especially natamycin, is not reaching there because of its high molecular weight. In those cases, we can think of giving intrastromal injections of voriconazole. And this is as seen in one of my case where it has healed nicely with the scar. So now if we do, after the scar is formed and after waiting for a few months, if we do a optical penetrating keratoplasty, the results are going to be much better when rather than doing a primary therapeutic keratoplasty in the first go. Therapeutic, again, see one of the ulcers where it was a very deep, like a corneal abscess, and it was not resolving with medications. So planned for a therapeutic penetrating keratoplasty for a better management. Again, in one of the case where it is not responding, we can go for a therapeutic penetrating keratoplasty. So this is a logarithm where when we do a direct smear examination, if it is positive, we can start antimicrobial, look for the response to treatment. If it is good, then we can continue. If it is worsened, then we can add or substitute medication. If it's still worsening, then we can go for a surgical treatment. So if smear is negative or the culture is not negative, then we can think of a drug holiday and do a repeat scraping and see. So to conclude, history provides clue about the etiological agent. We should check for local and systemic factors. That is why history taking is very important. Detailed slit lamp examination and documentation is mandatory. It will help us to know whether it is progressing or worsening. And rapid diagnosis can be provided by initial examination of the smears using various staining techniques. And as I mentioned, algorithm can be used to treat based on the initial laboratory report. Any unusual clinical features, we should ask for special stain. Especially this holds true in cases of nocardia or mycobacteria or acanthamoeba or pythium, where the clinical features are not very typical. We can think of any special stain. Mixed infection should be kept in mind. If we do not have a smear, if the smear is negative, culture is negative, then think about doing a drug holiday. Stop all medications for 1 day and then you do a smear the next day to see what the organism is. And if the direct smear is not possible or the infiltrate is very deep, then we can think of doing a corneal biopsy or a confocal microscopy to help in these cases. Send the tissue to microbiology and histopathology in patients undergoing keratoplasty. Sometimes patients come to us with a perforated ulcer, so there is nothing to scrape. So when we are taking these patients for a penetrating for a therapeutic keratoplasty, then in those cases we can think of we can take a back button scraping, or we can take from the site area whenever we are doing the scraping. So at least by the next day we will have some organism to give us a clue how to start the post-operative regimen. Thank you.
So at this point, there's a nice presentation, Dr. Shruti Rekha. You are in this very small time, you're covering the entire whole panorama of the microbial keratitis, including the viral too also. So I'm just sharing your presentation in 4 parts. First is suppose I am the solo practitioner. I don't have the multi-specialty facilities are there. Most of us, actually we are practicing by our own. Most of them are not in the institutional setup. So just from for first part of your presentation, what are the things you should be, as a risk factor, we should mandatorily ask for the patient whenever a patient comes to us?
So first of all, when we are taking a history, first is the ocular history, then a systemic history. So ocular history of trauma is very important because we come from an agricultural background and many of our patients are from the village area, rural background. So that is very important. The educated ones will give you history of taking a bath in a swimming pool or wearing a contact lens, but it is this uneducated mass that we have to extract the history from. That is an agricultural paddy leaf injury or something insect falling into the eye. That is what they will give us. Next is we have to ask them, show all your medication. That is what I tell all my patients, that you show whatever medications you have and whatever prescriptions you have. There will be some lotiprate somewhere written, or a prednisolone or a dexamethasone written, or even an
Most of the
NSAID.
time, actually, patient have been there going to the local pharmacy, and pharmacy giving the combination of the one antibiotic and the dexamethasone combination, and they're putting these things by their own because redness subsides. They are very happy, but the ulcer is worsening. So definitely, we have to be in recheck the thing with what the exactly the medication going on. That's it. Any specific thing you want to be sure, and I mean, tell us that which we should be as a general practitioner, as the general ophthalmologist. I'm the suppose I'm the general. I don't have the cornea backup. So patient come to me first time to ask. So this actually the webinar is made in such a way that most if someone is don't have the cornea backup. So what should they do this thing? Diagonal. So first clinical history part that I came to understand from your point. You are absolutely right that we have to take the history of the any what is the onset, any stuff trauma is there or no, any stuff specific contact lens use, a pond bath is there. Any specific other systemic thing you want to proactively ask to patient?
Yes, diabetes, because now many people, even from the village or rural background, also are having uncontrolled diabetes. So that is one thing, diabetes, and any other arthritis. If the patient is on immunosuppressants, those things, again, we have to ask them. The other thing, NSAIDs, which I was just about to tell. Now, NSAIDs is also readily available in the market as topical steroids. And I remember in one of my patient, I was posted in the OR, and the patient was posted from OPD for a TABCL. And when I post-operatively, when I saw the patient was actually prescribed NSAIDs, antibiotic NSAIDs combination before cataract surgery, and the surgeon on the OT table saw that it had perforated and referred the patient. So NSAIDs is again a very it is a widely used drug, and that is one thing that we have to be very careful, especially in patients with a poor ocular surface. So first, when we are taking a systemic history, diabetes definitely, history of arthritis, dryness. That is again a very common. That is an underrated thing, but it is becoming very common. And we should also do a good clinical examination. Sometimes they'll be having a coexisting nasolacrimal duct obstruction. So doing a syringing in a routine setting. Yes, syringing is a thing that we do for our pre-cataract surgery patients. So syringing can be emphasized. We can do it. And looking at the patient when in the
So
slit lamp.
whenever I'm just at this point, I'm just holding you. So whenever a patient come to us, I am the only, suppose the general ophthalmologist, I don't have the cornea backup. So if the microbial keratitis come to us, so whatever we learned that from your slides and whatever we are usually being a cornea person practice, so we ask very basic three things. Whatever he was telling, the whether the patient having a history of any trauma is there or not, what is the contact lens use is not, whether they're diabetic, we proactively ask the patient, are you diabetic or not? Even very rapid, even also whenever we are seeing the 70-80 patient per day, we write down the DM, so a history of DM is there or not, or DM under medication. So that is one of the very positive clue that those are susceptible for the infection. One thing always, whenever any ulcer comes, whenever before doing any microbiological test, we ask the patient whether any history of recurrence is there or not. If the history of recurrence is there, that is in much favor of a viral etiology. So that is one of the relevant positive history we are taking from the patient. That's a very, and another thing, whatever you were added, routinely we are asked whether any watering there or what are the lead, I mean, any pathology, adnexal pathology or any history of DCR, DCT or watering from the eyes there on the. And sometimes the village patient come with a hidden foreign body under the fornixes. So we have to evert the lid to us. So this is the actually history part. So I'm just requesting the Nilesh Mohan sir. Sir, you want to add something which you should be take care for the history part, sir?
At the outset, I would thank EIZOC for giving me the opportunity to be here. And really, Dr. Rekha has very nicely, crisply elaborated everything in so much of detail that I think in totality she has covered it up. But having said this, I would say that each ophthalmologist is not having the access to all the things present, but he has to use his clinical acumen, which again she has pointed out in the presentation. So I would say it's a very complete kind of a presentation she has made for the PGs and as well as an update for the practicing of ophthalmologists. So in the history, a little bit of an extra chair time is required in these cases. Because usually when you see, when the residents have seen or you have seen a busy patient in the OPD, you may have skipped those findings. The matter which you said that certain foreign body in the cornices, those things, those kind of thing, which is there, and it's a continuous cause of irritation. So those subtle things have to be looked upon by giving a little bit of an extra chair time when you see in the cornea clinic in the new patients. So those things are to be definitely looked for. And the examination part she has discussed very nicely. What I feel is that in any case of corneal ulcer, your approach must be very clear with whatever capable resources you have. The moment you think, I mean, you have to assess the ulcer, what severity it is, whatever be the cause. And when you are following it up, if the progression is there, and you don't have the access to those things, you immediately send the patient wherever it is required.
Exactly.
Because otherwise, it is a devastating thing. I hope all of you will agree. I think Dr. Reena would add upon those things and we can come up with this with certain points in the discussion. Dr. Reena?
Thank you so much, sir. Very good evening to all of you. So it's a very good presentation. I just want to clarify one or two points. On history point of view, recurrence is very important, as Dr. Sarkar has said. If this recurrence is there, you should more of think about viral. But again, you should take care of the thing which in presentations he has already mentioned. Viral mostly recurs, but sometimes because of the recurrences, it predisposes secondary infection, mostly fungal. So if fungal infection is coming, clinically it looks like fungal and history of recurrence is there, then again, against the rule, you can give combined treatment of fungal and antiviral. Okay. There is one thing which I would like to add upon again, that in non-responsive ulcers, even if your sensitivity has positive and you have started with the correct kind of drug and you have confirmed it with the culture sensitivity, still it is not responding, then you should actively look as a doctor about the control of sugar level. Whether if they are taking oral, shift them to insulin, take care of their blood sugar level. And other than that, you should see as very carefully if there is any local predisposing factor which is hampering the healing of ulcer. So it is very important. Sometimes the ulcer patient has VKC along with it. So you invert a lid, see large papillae is there, you should treat it again. Obviously, you cannot give steroid, but local things should be searched. Syringing is one of the things, but in active ulcer, you should not do syringing or avoid it because you are going to spread the organism from one place to another. But that sometime might be required for the culture sensitivity purposes. Also, one thing I would like to insist upon, if you people are agreeing, we people are practicing alone out of institutional setup. So clinical acumen is very, very important. So if there is no gram or KOH facility is there, then you should start on the empirical treatment, including antifungal treatment as well. You should not wait for the fungal report to come because there is a study and it's already been documented in the books that when you are diagnosing a fungal ulcer on your clinical basis, there is 61% chance that you can be correct. So start the antifungal treatment as well. Okay. And empirical treatment, you should start without waiting for any reports to come. If it is not healing, you can change it with the culture sensitivity reports. Okay.
Ma'am,
And
just I'm sorry to interrupt at this point. Ma'am, suppose we are planning for the, suppose I'm the solo practitioner, I'm practicing for the cornea, corneal ulcer patient to come to us. So we are empirically, we are not, I don't have the facilities for the gram and KOH. So we are starting the empirical therapy. For the, what is your recommendation? What you prefer in your practice for the both the microbial cover and the which one is the
as a corneal specialist? Think as a Ophthalmologist.
Ophthalmologist.
Look at the ulcer. First thing we have discussed: size, location, and the depth. If
Exactly.
size is 2-3 millimeter, it's less than 1/3 of the cornea is involved. Margin is clear. It's not very aggressive looking. It's not feathery margin. You can start with the monotherapy of the fluoroquinolones. That too, 3rd, 4th generation fluoroquinolones should be preferred, until you are suspecting very rare infection like mycotic. Otherwise, moxifloxacin is recommended. And Ciplox and Oflox is added or considered only when you are suspecting mycobacterium or rare infection. Otherwise, fluoroquinolone, I personally start in these ulcer fluoroquinolone and tobramycin combination in drop form. I don't prepare tobramycin for these small ulcers. If I find, if I have any doubt regarding the fungal thing, and if I don't have any clinical backup or pathological backup, I start antifungal topical along with this and cycloplegic and anti. If the
So
ulcer
you
is a
will-
little deep or a little bigger, then what we do, we start on empirical therapy, which includes preparing the aminoglycoside, most preferably, along with cefazolin or ceftazidime if we are suspecting. I prefer cefazolin instead of vancomycin or ceftazidime. Obviously, cefazolin has better coverage for gram positive and ceftazidime for gram negative. If you see the causes of ulcer, bacterial gram positive is more prevalent than the negative. So more common will be more right. So start with the empirical treatment. If supposedly you get culture sensitivity, then you can change the treatment. But if you don't have culture sensitivity and your ulcer has started healing on the treatment, continue aggressively sterilization phase with the empirical treatment only. Once you start healing, definitely don't forget to decrease the frequency of empirical treatment, because these drugs are toxic as well, because high
Exactly.
concentration. So healing phase, decrease your empirical treatment. Even if you get the culture sensitivity test and your ulcer is healing well, you don't have to change the treatment. That is what I feel.
So routinely in all your cases, ma'am, when you were suspecting the bacterial one, you were starting the moxifloxacin and along with the
No.
tobramycin.
Small ulcer, superficial ulcer, I give moxifloxacin along with tobramycin because I want
All
a
the
little bit
cases.
of,
All the cases.
because I want a little bit of gram negative coverage, because I don't have KOH or culture sensitivity reports at hand. So I want to cover as much as I can.
Just at this point, ma'am, I'm just with due respect, just heard you. I'm just going to Nilesh Mohan, sir. Sir, what is your recommendation? What do you follow, sir? As empirical therapy.
I would say that for smaller ulcers, I would agree to Dr. Veena. I mean, when you have a very small abrasions, little bit of an infiltrate, you start off with the fluoroquinolones only, and if it's a slightly larger size, you add on those tobramycin. Even you can start off with only the broad spectrum fluoroquinolones and follow it up for a day or two. If it's responding, you can go ahead with that.
Exactly.
But
I agree.
if it's moderate to, I mean, initial presentation is a little bit severe, then you go for the fortified ones.
Yes.
Empirically. This is what we clinically follow. And I would say that the practitioners, wherever they are, I mean, it's easy to even prepare a fortified antibiotic preparation. But despite that, they have the access to these two. At least these two should be started if you are not seeing that it's fungal. If it's fungal, then again, you have to start off with antifungals along with the antibiotics and send it, because now when the infection is mixed variety and you are seeing that there is no improvement, even no improvement is seen as a sign of stability and improvement. But these patients now are going to take a longer period of time. So they need access to some KH staining, gram staining, and those things, microbiology and lab testings. So that usually doesn't happen, and many people who are busy, they don't go for that. And if the patient doesn't turn for follow-up, I mean, then those practical implications have to be kept in mind, even if the clinician knows that this has to be done. So
facility constraint is also there, sir.
Dr.
Yes, sir.
Nilesh,
Yes, sir.
just one question, Dr. Sarkar. One
Yes, sir.
question to Dr. Nilesh.
yeah.
Yes, sir.
How long you are going to wait and monitor whether there is an improvement or not? 24 hours, 48 hours, and then decide whether the ulcer is stable, improving, or not improving.
Usually, these patients are followed up daily. In a clinical practice, you can't call for daily. At least you can call alternate day, depending upon the severity and the size. If the ulcer depth is not that much, it's not very large, then you can afford to call for a follow-up after 2 days. But you can't afford to call the patient after 1 week. Because if anything catastrophic has to happen, it will happen very fast. So ideally, these corneal ulcer patients are to be seen daily.
Yeah.
Yes, sir.
At this
Sir,
point, I
I
just
would
want to
like
add
to
thing.
add,
Yes,
just
yeah.
I'll take 1 minute.
Yes, ma'am. Yes, ma'am.
I would like to add upon the things which Dr. Nilesh sir has already told. Pranav Ranjan sir, there is a typical treatment protocol, what we
Protocol,
cornea
yes.
people follow. There is a 2 phase of treatment, sterilization phase and healing phase. In sterilization phase, what you have to do for 48 hours, you have to give 1 hourly antibiotics or even 30 minutes or 15-minute antibiotics round the clock. If after 48 hours you see that not even a slight of improvement is there, you should think of something else. Otherwise, if a little bit of improvement after 48 hours is there in any kind of ulcer, despite the sterilization dose, then you should think that it is not going to heal. Either you can wait another 3 days with the tapering of 1 hourly in day waking hours. Again, after 72 hours, if there is no sign of healing, either you should recheck with the clinical features or recheck with the local factors hampering the healing, or recheck your culture sensitivity and think that it is not healing. So either the diagnosis is wrong or the drug sensitive should be rechecked.
So that means
72 hours should be a cutoff, rough
Yeah.
cutoff, sir.
yes,
72
that,
hours.
that means you can wait for 48 to 72 hours before you finally decide whether how the ulcer
Yes,
is
sir.
behaving.
Yes, sir.
Otherwise, you
Yes.
give it to the laboratory and other things so that you
Yes, sir. Yes.
technically
There is a
come to an
fair,
analysis.
yes, sir. There is a fair reason for that. Despite you are giving the correct treatment, supposedly aminoglycoside or cefazoline or even voriconazole, the initial response of any medicine will be a little worsening of clinical feature because response has started. The healing will start. The macrophage and the lymphocytes will come and they will start releasing the toxin, and the sloughing will increase on the first 24 to 48 hours. So we should not be in hurry for changing drugs into 24 to 48 hours. 72 hours are a fair cutoff for thinking about something else.
Okay, right. Thank you so much.
And
And
just
Dr.
can I
Dr.
add
John,
something, sir?
Dr. John, there are 6 residents also. You can ask them also. You can involve them for a
Yes.
discussion. Right, please.
Yes, sir. Yes, sir. So, what basic thing is that actually, if I was fortunate that I'm working in a setup where there is a microbial facilities are there. So, whenever the patient come to us, if the ulcer is more than 2 millimeter, we routinely scrape all the ulcer. Number one. And I agree with the madam. Actually, we try to finish if it is suppose the history is not suggestive of any fungal, or the clinically it is not looks like a fungal. If it looks like a pure bacterial or something, it may be the positive or gram positive, it may be the gram negative. Then usually fast before the scraping instant we're not getting the report. It will take at least 1 day in my hospital. So usually what you will do, start the one of the only fluoroquinolone, is the 4th generation with having the broad spectrum coverage. Nowadays, we prefer to 0.5% your gatifloxacin, which is partly main the part of the gram positive as well as the gram negative. What the madam was telling, I agreed with ma'am that what she is giving the combined medication. So we are giving the one medication. This compliance will be much better. Along with the some of the associate treatment like cycloplegic and if the patient symptomatic analgesic like that only. And sir, we in our setup we are waiting for the next. We are called the patient next morning. By the time report has been come, and I can clinically what the madam is saying, she's absolutely right. It will take at least some times to be drugs work. But in spite of the aggressive medication, if there's a progressive worsening is there, specifically we know the symptomatic, why the patient is very much symptomatic, on if the patient is symptomatic, very much symptomatic, if the pain is increased. So first of all, we look out the why the pain is increased. Is it due to infiltration or ulcer worsening? Or sometimes what happens, there is a sterile your uveitis is there and they cause a shoot of IOP due to the your hypopion. So always never forget to check the digital tension. Don't do any AT for those or any NCD you can do, but it will not give you the exact result.
Exactly.
We always routinely check the digital tension. If the shoot of IOP is there, and most of the time the pain is complained due to the your cyclopegia, due to the basically because the ciliary spasm is there, you had to be cycloplegic die, and due to the intraocular pressure, in spite of the giving the more and more your another oral analgesic, patient will be much more comfortable. And regarding this scenario also, we prefer the either your atropine or the homatropine drop, because we don't give the cyclopental because cyclopental itself is causes the uveitic. So as a cornea person, over whatever will do, prefer if you want to do the even tropic acid plus this is mid-doses. So keep in mind, we need a cyclophagic medication. So usually we have to, along with that antimicrobial therapy, we have to give an adjunctive therapy to give the relief of the patient, not to in the form of the oral medication. So in the form of the cyclophagic, either the homatropine or the atropine along to the severity of the ciliary spasm, and along with the intraocular patient, which is measured with the digital tension, or if the hypertension increase. So definitely we have to be think for the conditions of the worsening, we have to take care. And if it is suppose a one-eyed patient, if it is ulcer is worsening, it will approach the limbus. If the scleral involvement is there, in those cases we added the, according to the scenario, oral antimicrobial therapy. If it is positive, we suspect it, we give the positive. If it is negative, we give the oral antimicrobial, which is cover the gram-negative coverage. And what the madam is telling, that sometimes some of the is so worsening. I'm just sharing one of my cases. Recently, last year, we have seen just before the All India, Kerala conference, one girl, she's doing the MD. She's wearing the contact lens. So morning time she came, Dr. R.C. Paulson, and she saw the signs and referred to me. So it's a very clinically, the re-infiltration is there, pseudomonas suspected. So I have given the script. I said that it was part of the ulcer is infiltrated towards the limbus. And she was very much symptomatic hyperpenis as a medico. So I asked them to better to go ahead with the therapeutic PK, because it's very much about to reach the limbus and the sclera. Once the scleral melt is there, is very worse, and the prognosis is very bad. So definitely she is from the, the Bangalore, some of the outskirts. So she took some times of evening time, the decision making like that. Though at the end of the evening time, when I saw him, by that time total entire whole cornea has been filled. So it is so aggressive worsening. So sometimes if the ulcer is also very worsening, in this scenario, you have to take the prompt action. If I don't have the infrastructure, so better to refer the person to the respective person who have the center, where the facilities are there to take care all those scenarios.
And the thing is, I need to clear here right now that you should, it's not about the taking decision. You should definitely see the patient after 24 hours, 48 hours, 72 hours. It's about the changing the treatment decision. That is different.
Dr. Sarkar, I have a query actually. In a case where you have a massive ulcer and the patient is not responding, and then you have tried out everything, you can't take the intraocular pressure properly except for the digital format. What is the role of any anti-glaucoma drug or IOP lowering agent when the pressure is apparently still okay? Is there any role? Do you have any this thing, or only when it is high you want?
Sir, whenever we're suspecting that there is a high IOP, most of the time patient complain the pain because of the ciliary spasm is there, and there is a hypopain is there. And that hypopain, nothing but that is the antigen antibody inflammatory reaction, and they just sitting on the trabecular meshwork. So we have to give some of the medication which can symptomatically cyclophagic is given in the form of the homatropine, atropine, the patient. And as an addition, we have to think why there is a Ashuta biopsy is there. So we have to reduce the IOP. Otherwise, the patient complains. Sometimes, in spite of the aggressive medication, patient complain. You can see the ulcer is reduced, but patient unusual pain is there. And that is the reason indication. Usually, we simply prevent the timolol maleate, provided the patient is not your asthmatic or heart block is there. We never recommend any prostaglandin analog. Those patients, because those are your prohibitic or inflammatory, definitely don't recommend. Along with the oral Diamox does it very nicely work, because reduce the aqueous production and symptomatic, it gives the very good relief to the patient, sir.
Okay. There are some 6 of them actually residents. Why don't you please involve them and ask them if they have any queries and things like that. We want a more interactive. Do you have any queries? Anyone? Dr. Jyoti Goyal, I can see. Dr. Amit Kumar. You can ask any question to the speaker or the moderator or the panelist. Dr. Asmita Adhikari, I can see you. Dr. Deepu, is it? Yeah, if you have any queries, please, we want a more active participation from you.
Can I add something, sir?
Please go ahead.
So whenever we have DNB and the fellows are in the social, so whenever we are taking the class our own DNBs, so we'll teach them such a way whenever the ulcer came to them. So 4 basic things they should not be forget. One thing that they take the history, whatever they already discussed. I'm not going to that again. That point for the clinical part, but documentation. What the madam was that is exactly what you have. If you don't have your camera system in your slit lamp also. You can draw the exact size, what is the then next morning, and nowadays everybody having the digital, we have the camera. So even we are taking our own patient's archive, and at the next day we can compare these things. Number two. Number things that is a rule of thumb that you should check the sugar level. If it's diabetic, do the FBS or PPBS. If it is non-diabetic, take the RBS. Syringing, in our case, we routinely do perform the syringing, because if it is NLD block is there, even also very severe, we send our oculoplastic consultant. They done the DCT or DCR according to the age or preference of the respective patient. And thirdly, we do the gram and kVh. If the ulcer is more than 2 millimeter, we have to, if you have the facilities are there, if you are a medical college, if you are in own interest, even our PG lab, and when I was in the doing my PG in AMC Dibrugarh, we carry the patient to microbial department and do the scraping there, and again come back to there only. So that is your own interest. We can do the thing. Even also, you can see the amazing feature of the gram and kVh, which is a very easy to do the thing. If you have a microscope or something, just mount it and say it. Even if you don't have gram facilities are there, at least you rule out that there is no any fungus. So you can treat accordingly to the whatever the situation. And the thing, if you suspect that the patient having it is not a perforated ulcer, but the eye is very aggressive. So usually we do prefer do an ultrasonography EIZOC scan to know whether any features of the endophthalmitis is there or not. These 5 things is very much mandatory. And now the scraping, once it has been done, then the management part, what the madam was telling, concise the thing in a very short way, that we give one of the broad spectrum antimicrobial therapy, what the Rina madam was telling. We try to give the 0.5% fluoroquinolone of the usually catifloxacin in the form, because there's some gram-positive negative coverage. And if I suspect before the cleaning, even also scraping, if you suspect that looks like your hypet is there, and there's a fungal history of injury, and is the occupation by the farmer or any vegetable injury, vegetable matter, and then definitely we have to add without hesitation, we are not waiting for the next 24 hours of report. Nothing harm on it. If you add it, rather you can get the additional report. If it is fungus negative, you can omit the medication, but you can add on the therapy like that. And whenever there is an ulcer is more than 50% involvement of the cornea, if it to the visual axis, if it to the pediatrics patient or extreme of the age, if it the debilitated patient, diabetic patient under chemotherapy, or the patient, suppose the severe dry eye patient, mainly the RA patient, JRA patient, then those patient, or if the limbal involvement is there, we usually add some of the systemic antibiotic. And here also we have the choice according to the situation, which things we are suspecting. So if you are suspecting for the gram-positive one, we usually amoxicillin clavulanic preparation. If the leads are very unhealthy, we are suspecting that maybe the blepharitis can be the causes. In this case also, we are in the doxycycline, the therapeutic doses. If you have the gram-negative coverage, then we are adding some of the therapy for the gram-negative coverage. And whenever the fungus comes positive, and if it is suspected the patient having the which fungus is there, if it is even also been gram and kVh, you can rule out it is a filamentous fungus, or if it is your candida one. According to the situation, if it is a filamentous one, we are adding some of the ketoconazole, and if it is if it is a candida one, we are adding the fluconazole like that. So you can treat your patient and you will give a very predictable outcome. But we should know the things, but when should you refer the patient? Or when should, that is the one of the things you can't treat, because even sometimes we are also sending some of the higher center if we don't have the tissue there. Suppose we have a eye bank, we have the taking the tissue from the Bhubaneswar LBPI. Sometimes we're thankful to the Sujata ma'am and all the eye bank team also. Even also sometimes we don't have the tissue, but the patient with the slough out ulcer is there. I think the patient need your urgent therapeutic PK.
And there is one thing I would, sorry to interrupt you. There is one thing. Before referring, don't be in hurriedly refer the patient. Start the treatment topical.
Exactly.
And at least globe integrity should be maintained before you refer the patient. Train traveling, even the flight traveling is not safe with a melted stromal cornea or a perforated ulcer, even if it is small. What easiest thing that you can do, it's very, very easy to do at least cyanoacrylate glue and BCL. And if you are competent enough to do, you can do AMG or scleral patch or even a small conjunctival patch with glue. Do this and then send the patient, so that patient should reach the surgeon in a integrated globe condition.
I just agree with ma'am, and just sound one thing add. Even what a traditional teaching is there, if you don't have the cycling glue on something, so you can simply do the tarsoref even also. If you suppose across the border, simply tarsoref can save the eye. If you don't, nothing is available, but the perforation is there, and you think that you are sending the patient from village to the 12 or travel for the train or bus, simply do a trastography. Then simply they can put the medication in between the gap of the lids, and they can salvage the eye, because globe salvage is very much important in this scenario.
Most of the cases they just hastily refer it to the specialist. Please do something before referring. At least patient should reach safely to the surgeon.
Now I'm coming to the second point. Suppose just this is also what I think the common question I was expecting that from that. Suppose the patient having the corneal ulcer is there, and then it's already scarred, and the patient having the senile gauge group, so they have the cataract. So what protocol you follow for the just before the cataract surgery, on what is your window period for waiting after the ulcer and in between the ulcer and the cataract surgery?
So here, I what personally have been followed and been taught at RPC. If you are already knowing that the patient was a bacterial or fungal ulcer patient and healed properly, and 3 to 6 months has gone, or 3 months at least has gone after healing, so without any prophylactic treatment, you can go ahead with the cataract surgery. But if the patient was a viral keratitis patient, I start prophylactic antiviral full dose at least 2 days prior, and then do the cataract surgery. In at least 1 week, I give full dose of antiviral. Other than that, if the ulcer has healed and it was bacterial and fungal and it's healed properly, I don't give any prophylactic treatment or any additional treatment. But in viral, I definitely do take care of pre-op and post-op. And in viral, I wait for 3 months at least post-resolution.
So that is very good important point. So should not be jump for the cataract surgery whenever the patient had a history of the corneal ulcer. And if you don't have the patient treated outside also, try to see that, just take some table time extra, see the paper, whether it is a bacterial or the what the madam was telling, whether it is a mainly microbial or it is a viral. If it is a microbial scarred is there, so definitely no need for the extra medication. But if it is a viral, like if you do any surgery on any surgical trauma, whatever, they landed up with the reactivation of the virus. So what the madam was telling, that's the traditional teaching. I do follow the what the Shankanatala protocol. We just 400 milligram BD 5-7 days prior to the surgery, and at least 2 weeks post-operatively, and we close those patients. We call at least weekly initially for first week, and we immediate first post-op day, then after 7 days, and then after 14 days. Not like other cataract patient first post-op day, then after 1 month, like that only. So this patient is very special case scenario. That is one of the most important information is there.
Any queries? Any queries? Since we are nearing 9:30, I think we should be. Any queries or any this thing from the residents? Any one of the residents here?
I have a question, sir. So, like, if suppose we have a patient in our clinic and in that patient is using cocktail of medications like antifungal, antibacterial, and antivirals. So, how do we? Are there any clinical pointers to say whether this is a healing ulcer or is it a toxic keratitis? What are the things we should look for clinically to differentiate between the two?
Nilesh Mohan sir, you want to add something? This is a brilliant question. This is a very sometimes we have seen the patient having one antibacterial, one antiviral. Yes, sir. Yes, sir.
$1 million question: which drug to withdraw? A patient has been referred with all the drugs added, and then there is some kind of a healing also. Then what to do? That is the main thing, na? I mean.
Yes, sir.
Yes. Like, how do we know that is it a toxic keratitis or is it a healing ulcer? Maybe the keratitis part has healed and it is just the medications. Do we need to stop the medications or which one to continue?
That part is an ulcer examination.
Exactly.
That part is an ulcer examination, and you have to follow the ulcer. If the ulcer is healing, you'll see the signs. For the signs of toxicity, you will see it in the normal cornea also.
In that case, sir, if you allow me, in that case, don't see the treatment part first. See it as a fresh case for examination and clinical evaluation. If the treatment has been given, everything is there in the treatment, antibacterial, antifungal, everything is there, and the still ulcer is aggressive, necrotic, satellite, feathery margin, what you will do? Take out antiviral first, withdraw antiviral, keep it on antibacterial, antifungal. If the ulcer has no necrotic margin, no feathery margin, but it is clean, punched out type of ulcer, which is metaherpetic ulcer or toxicity. And here comes the confusion. Either it is metaherpetic or it is a toxicity. In that case, you should take out the topical toxic drugs, or you should decrease the frequency of drugs and see what happens. But again, the non-healing ulcer and the resistant metaherpetic ulcer, there is a catch. There is a catch of duration. How long this ulcer was there? If it is fresh, within 1 or 2 weeks, patient has come, it can be a non-healing ulcer. And if it is a metaherpetic ulcer, there is a history of long treatment, still not improving. You should take out the medicines and see on the lubricating drops with the minimum medicine, and without any toxicity drug, it will heal. So take ulcer as a fresh case. Use your diagnostic skill, clinical history. Again, work it out as a fresh case. I think we should work it as a fresh case. And then take the decision.
Exactly.
Ma'am, one more question. Like another doubt is like if the patient is using so many medications, like if it's a fungal ulcer, will it still retain its characteristic fungal characteristics when the patient is using antifungal treatment along with the other treatment? Will it still retain the
if it is
characteristics
non-healing ulcer, it will have the same characteristic, even if small, large. But if it is healing, hypopyon most probably will be going very slowly. The hyphae will be decreasing, and the endothelial plaque will be decreasing. So it is healing. In that case, what you should do, ask the history again. If you were there in the presentation from beginning, ask the history again. Was there a recurrence? Was there a redness, pain, or photophobia episode 1 year back or 6 months back? Then it can be a case of viral keratitis which has deteriorated the ocular surface of that particular patient, and that particular patient become very prone for secondary fungal infection and bacterial infection. So antiviral you should not take out at this point of time. But one thing what you can do a fluorescein stain. Okay? If the epithelium is closed, most of the fungal cases, when it is healing, you will see epithelium is closed, but stromal abscess is still there, hypopyon is still there, hyphae is still there. Take out the topical antiviral. Continue with the oral antiviral and full dose of antifungal treatment. So again and again, I will insist one point as a senior from of your and you as a resident, work each and every case as a fresh case. Use your options, okay? And then you have to calculate the things. Okay, fluorescein staining is one catch which you should never miss. Recurrence is another catch which you should never miss. Okay, systemic and local condition which is stopping the healing, you should never miss. And then think about healing or non-healing. Okay, am I right, sir? Do you want to add something else?
No, it was all. It was all good. I mean,
very nice.
Examined as a fresh case when a patient has come to you, and the question what she asked was related to evaluation.
Exactly.
Either the patient has come to you with all the things without any medications, or it has come to you with the medications. Now you need to see what kind of an ulcer is it. Is it a mixed infection? Because in all variety of cases, you can have so that certain points will come from the history, and certain things you will see. Whether it is giving a healing type of an ulcer where you can see the edges and those things, corroborated with the symptoms earlier, or the documentation which has been done earlier. If no documentation is earlier, then the symptoms have to be corroborated. And then, as per the findings, you just corroborate your findings and come to a provisionally in your mind when the patient has come to you first. And then subject to the investigations. The first, I would say that yes, the gram stain and KOH becomes quite important and very, I would say, for institutional, I mean, when you have referred, we are seeing referred cases, you have to do the first time things. Then the question comes of which drug to withdraw. As you rightly said that when to antiviral, when the already things are aggressive, there's no point the antiviral should be there. The whole cocktail of every drug is there. I can understand antibiotics and your antifungal. And then you can see that there are long-standing ulcers. You're given all the antibiotics. You have seen the sensitivity. It's still not responding. That scenario also occurs. So then comes the question of how to go ahead with the next set of things. Either you go in for intrastromal interventions, taking AC taps. So those are those non-resolving cases which are worsening. Those who are going towards therapeutic keratoplasty. So everything will be the patient will give you the time if the patient comes for follow-up. If the patient hasn't come for follow-up, then things may go up totally wrong or totally haywire.
Yes, sir. Yes, sir. There is one more thing, sir. In these kind of ulcers, what we usually see, the epithelium closes, but the inside thing is going ahead. So in these cases, scrapping will not help you a lot. In that case, what you
When
can
the
do,
epithelium is healed up, then the different thing. Then the
then
long
what you
term.
can do, you can simply pass a suture and take it out, cut it and send it for culture sensitivity or gram staining. Or you can do a peripheral, healing peripheral punch biopsy. A punch biopsy is not like you do through and through. It's 2 millimeter punch biopsy. You can see an organism can be taken from there, but try not to take it from the necrotic area. Then there is chance that we can find the organism even without stopping the treatment. Previously, it was recommended that you stop the treatment for 24 to 12 hours, then you do the things. But nowadays, I think people prefer not to stop because it's too risky to stop. But instead of that, you do some deep kind of culture sampling.
I 100% agree with them both, Nilesh sir and the ma'am, Rina ma'am. Definitely, what we are follow the same thing, and specifically keep in mind that topical antiviral is very much toxic medication.
Very much toxic, right?
We should not use it more than
Very toxic.
14 days.
Yes,
Sometimes
yes.
we see the patient
This is very, very good point to add.
antibacterial, antiviral, and topical that ointment 5 times for the more than months. So definitely, whenever think there is epithelial defect is there, it will probably the neurotropic also something is there. Underlying
Exactly.
it, or it may be the necrotic, which is either acanthaviva or the fungal one, most commonly associated with the necrotic, the viral underlying etiology. So
Sir,
you have to change
yes.
your the plan of action and never use the suppose if person epithelial defect is there, simply stop your antiviral after 14 days, do the therapy, lots of lubrication and therapeutic dose of the oral antiviral, and along with that give the lots of your whatever the microbial report come, it will give the immensely good result.
Absolutely agree. Sometimes what happens, a patient used to go different doctors. They see the viral kind of ulcer and they just give the topical antiviral. But you should definitely take out time and check the bag of the patient for how many times and how much, for how long duration he is using topical antiviral. So better if 14 days has already happened. I totally agree with you. Take out the topical antiviral and I think this is very, very, very toxic. Epitheliotoxicity of topical antivirals are already been documented. I personally would like to tell resident here that I and my institute have taught us to follow herpetic eye disease treatment trial, and it is very, very practical in treatment of viral keratitis. And fluorescein staining is utmost important in viral keratitis.
I just one thing want to add, ma'am. Even it is a very age-old procedure, we are checking your corneal sensation whenever you have a doubt.
Yes, yes,
it will give
yes.
you the immense good clue.
Sensation should be also checked.
Sometimes what happen, and as if we are fortunate, we are seeing lots of mix and match combination of refer patient. So one patient come with a very severe inflamed eye, lots of medications given, and then we respectively ask the patient. So we rule out the NLD blocks, everything. She had a history of the recurrence. This time actually superadded infection was there. So, but it was also inflamed. So scraping everything comes negative. We give the broad spectrum antibacterial, and along with that, the oral therapy is oral because corneal sensation grossly reduced that time. Though there is also there's definitely reduced, but it is grossly.
I agree. It's a small test, but very helpful. I totally agree with you. Very helpful.
Then you simply do the tersotherapy, and once the epithelialized, we have started the oral therapeutic dose of the your even oral steroid, and the patient will absolutely doing well.
Absolutely agree. Totally agree with your points.
Never forget to taste if you think this could be viral in the exam too also, and you should check the corneal sensation, but separate strip, not the same strip for the both eyes. Separate strip. I think we have Dr. Ashmita is here. She has some query. Yeah, Dr. Ashmita, please.
Good evening, respected ma'am and sirs. So I have a query about viral keratitis. So in stromal keratitis, how do we differentiate between, for example, deciform and immune related, because both will have ring-shaped stromal infiltrate. So by just slit lamp examination, can we differentiate between types of stromal viral keratitis? like a characteristic appearance is present in herpetic epithelial keratitis dendrites and also in geographic ulcer. So can we differentiate by just by slit lamp examination between the
Can I take this question, Dr. Sarkar, if you don't mind?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Please, ma'am.
Yes. So, see, you have a slit lamp and you have a patient. So, start from anterior to posterior. See if only epithelium has involved, you do a fluorescein stain and you see it's a geographic kind of ulcer and epithelium edema is not so much there. And the stroma is a little clear, but only epithelial and subepithelial part is hazy. So, it's a geographic ulcer. See, but it's not a clear-cut line between geographic ulcer, stromal, or disciform. But disciform again will be a little different. Sometimes geographic ulcer can also have corneal edema with a stromal involvement and infiltration. So it can be a stromal keratitis, right? Disciform keratitis can have epithelial defect as well, but I have not seen it very much associated with epithelial defect. It's more of an immunological type 3 immune reaction, as much I remember from textbook, right? And it's a disciform keratitis, so it can be small or large, sometimes involving the whole cornea. You can clearly see the corneal edema and the endothelial side, wave-like edema. Okay, have you seen disciform keratitis before? So edema which will be very, very clear. It's not like stromal keratitis alone. Sometimes stromal keratitis associated with disciform keratitis. Okay, so see the which layer is involved, how much cornea edematous, whether there is capies or not, where there is a clear folding of endothelium with the edema in the center, like button-like edema is there. So examination is exactly, it's written like in textbook. You can see the patients, see it 1 time, 2 time, 10 time, then you will be able to do it clinically without even thinking, right? Okay, but fluorescein staining and stromal observation and edema, endothelium and capies you should see. All these are clinical points you should take up in your mind, and then you can differentiate all these 3 things. Am I right, Dr. Sarkar?
Please unmute, Dr. Sarkar.
Unmute myself. I agree with ma'am. So basically, what the madam was nothing. All are absolutely were clinically follow day-to-day practice. And one thing is very suspected. Whenever the DM folds are there, nothing is there. Patient complains of DM folds, and a history recurrence. Sometimes mild corneal edema with DM folds. So that is much more at this point of life. We can know this is purely your endothelitis, HSB endothelitis, or it's a disciform partly treated elsewhere. Because if you not give the exact therapeutic dose of the acyclovir along with the proper your anti-inflammatory medication prednisone, let's say proper dosing, sometimes what happens, we are so scared to give the full therapeutic dose of the, because even also pharmacist and doctors given the wrong dose. He has asked to take the 400 milligram 5 times 14 days. It is you will have toxicity, but it is not that. Whenever the disciform keratitis is there, or whenever there is actually stromal keratitis is there, you have to give the full therapeutic dose of these things. And what the madam was telling, that absolutely that is the point. Even clinically you can differentiate the epithelial one, not only the geographical and the dendritic. It was very clear-cut design. But suppose if you have the epithelitis, whatever the epithelitis, this is a stromal one. It may be without epithelial defect or with epithelial defect. It may be the purely the your endothelitis or disciform one, or it may be the keratouveitis. Even the sometimes uveitis, we don't know that sometimes it is HSV associated. Simply present with the recurrent uveitis along with the shoot up IOP. Yes, sir. You sum up the things, sir. Yes, sir.
Any other postgraduates have any queries? Because it's
wonderful discussion.
Yeah, very nice.
I'm really thankful to EIZOC for giving us the opportunity.
Thank you then. Thank you, Dr. Sarkar. If you have listening, because it's already going towards 9:46, nearly 10 o'clock. So I think we thank you everything for all this thing. So from the ARC EIZOC side, I'd like to propose a vote of thanks. I want to first of all thank the speaker, Dr. Smruti, Madam.
Sir, you are muted. Sir, unmute yourself.
I'm so sorry. I'm so sorry. Can you Okay. So I'd like to propose a vote of thanks on behalf of ARC EIZOC. First of all, I'd like to thank Madam Dr. Smruti Priyadarsini for giving us a very comprehensive talk, insightful as it is, and covering the whole topic of microbial keratitis in a very short and very nice way. I'd also like to thank Dr. John Sarkar for very, very aptly moderating the session, bringing on to life a good amount of discussion from the expert panelists, the Professor Nilesh Mohan sir, for giving us the very invaluable inputs. And I'd like to thank also Dr. Reena Singh, madam, for making a very, very lively discussion and giving a very, very insightful and meaningful input from your side.
Sir, you got mute, sir.
Again.
Again, I'm so sorry. I'd like to thank the residents also for joining us and participating actively for making this ARC webinar successful. And last but not the least, I would like to thank the President, Dr. Pranav Ranjan sir, for giving us this, for actively supporting this ARC webinar. And I'd like also to thank our Honorary Secretary, Dr. Soros Bhattacharjee, for giving us all the support that we need. Thank you so much. And it's been a really nice discussion. And again, especially want to thank the speaker, the moderator, and the two expert panelists for a very, very lively discussion.
Thank you so much, sir.
Thank you. Thank you. Thank you.
Thank you so much.
Thank you. Good night.
Thank you, sir.
Thank you. Good night.
Thank you, sir. Good
Good
night.
night.
Thank you, sir.
Thank you. Good night.
Thank you, sir. Good night.